Lunch. And if you are new to Ethics for Lunch, there is a verification on the screen. We'd like to have you all here and text that you're here because it helps us support the Ethics for Lunch. So, everybody has lunch? Everybody's quiet? We'd like you to verify your attendance, please. To get us started, we're going to talk about a difficult topic. It's decision-making within a resource-constrained healthcare system. At Johns Hopkins, we all manage very complex, difficult cases, whether it's from our local community, from the United States domestically, or if it's a patient that comes from around the world. An important part of healthcare decision-making is actually the cost of the care. A lot of times that's not brought up. As providers, we just give the patient what we know they need because we're taught that. However, that's a topic that does need to be talked about. So in this discussion, we will generate some interesting thoughts, some difficult questions, and we're all very happy to have you here. Our ethics panel is happy to have you here, and it's interesting to know your thoughts. While the best interest of the patient certainly is the top priority, disregarding the cost of factors or disregarding the cost of the care is not possible, particularly for hospitals which provide a large portion of uncompensated care and already stretched financially. Our case today is a reflection of some of the recent cases that our consult team has had. So it'd be helpful to bring this into our lunch discussion today. As we talk through the case, I would invite you all to think about the listed questions and objectives, as well as 4 principles and how they fall into our decision making. The first is autonomy, which is respecting the patient's choice. The second is beneficence, which is we do what we know is in the best interest for our patient. The third is non-maleficence, and that's to do no harm. And the fourth is justice. Societal justice, what we do for our patient, is it the best thing for society as a whole? And think about resource allocation when you think about justice. We have an amazing panel today. I'm very excited for each one. So on the far end, we have Louise Knight, who is the Senior Director for the Duffy Family and Patient Group in the Oncology Division. Melissa Richardson is our Vice President for Care Coordination and Management for our hospital. Dr. Charles Locke is an Assistant Professor. He did work with us for a little while in International, so he has a very wide knowledge of patients from all over the world. He is also the Senior Director for Care Management for the hospital. And Alyssa Smith-Mitchell, is a Senior Clinical Social Worker and also a member of the Ethics Committee. So while we hear from them individually about this case, I want to get us started with the case. I want to remind you that for the point of this discussion, the term uninsurable and undocumented are going to be used interchangeably. The case that you have in your handout has been de-identified for privacy. So, Mr. C.E. is a 27-year-old, non-English speaking, undocumented immigrant with a history of hypertension, type 1 diabetes, insulin dependent, and progressive chronic kidney disease, which now requires hemodialysis. He's had multiple emergency department visits and admissions to Johns Hopkins Hospital over the past year and a half for fluid overload related to his kidney disease and an inability to adhere to his medical regimen. As an outpatient, he is followed by a community health center, and in that health center, he has developed many friendships with other patients who are of the same ethnic background. He reports that he has siblings on the West Coast, but he is estranged from them. Mr. C.E. has historically relied on a local friend for his financial and housing support. However, this friend is no longer in the picture, and Mr. C.E. has no financial help at this point, for housing or otherwise. The most recent hospitalization found the patient to be refractory to pharmacologic management for his kidney disease. Therefore, he was started on hemodialysis as an inpatient. Additionally, thinking about hemodialysis as an outpatient, he was given an AV graft, an AV fistula, plans are being made for an outpatient chair for hemodialysis. So thinking about the principles of ethics, thinking about our health system and the constraints that our health system has, thinking about the tough questions we have to ask when we're managing these very difficult, complex patients. I'd like to open the conversation to our panelists and ask them their thoughts about the case, and then we can entertain further questions. So, who would like to go first? Allison.
I was trying to push the button, but these things
Oh,
don't
we have
like
to turn it on underneath.
There we go.
I got it. I'll jump in first because I was involved with this case as I think just, maybe not Louise, but everyone else at the table was. One of the complicating things here was the fact that we knew or strongly suspected that at the time that the patient was put on HD, that would be for life. So essentially, in discharging the patient out to a community hemodialysis center and signing a letter of agreement for that, it's the equivalent of a lifetime guarantee to continue that medical management basically until the patient passes away, which for the hospital equates to like a mortgage for an individual patient. And just before I came here today for the heck of it, I ran a report to look at how many patients like this. We have now, not all of them are international patients, or undocumented patients rather. Some of them, just for other reasons, are uninsurable. And at any point in time this year, we've had at least 27 patients on perpetual hemodialysis when the hospital's dying. And that becomes, a question for us going forward. How much of that can we do? Where does our obligation begin and end? Where does the state need to step in? Where does the federal government need to step in? We're going to have answers to any of those questions. But that's what we grapple with as we look at what patients without any insurance and without any potential for insurance have when they leave. And so each year we sign letters of agreement for assisted living facilities, for nursing facilities, for HD, to a lesser extent for home care and other support that might have no end. And obviously this isn't what hospitals were initially set up to do. It's not what we're funded to do through the state, but it's very much something that we have to do for moral reasons, for regulatory reasons, for ensuring a safe discharge for patients when they leave the house. But it has cost attached to it. It's something that we grapple with probably on a weekly basis.
Thank you. Melissa, do you, are there any thoughts on your part from the very beginning when the team sees something like this that they could put into place? Do we have any policies or procedures?
We do not have firm policies and procedures related to particularly undocumented patients that are going to require ongoing care when they leave. It's really dealt with on a case-by-case basis, which is something of a problem for us as we're running full capacity and we're doing everything possible to get patients out the door. It really means that at the tail end, you're looking at what your options are and what they're going to cost. There has been a hesitancy, to be fully transparent, there's been a hesitancy to create a blanket policy about what we would do for this, because we really do look at everything on a case-by-case basis because of the price tag and the time commitment associated with it. But it does put our care management team in a bit of a bind when they're trying to move somebody along to transition their care, and they have to come to me. And in these cases, I actually run these issues up to our CFO or our COO for signature because of the doctors involved.
Oh, there was a gentleman who had a question.
Sorry to butt in, but is this particularly in Maryland because of the reimbursement, the structure for the hospital, or is this kind of thing experienced by hospitals around the country?
It's around the country.
But to your point, the GBR, because we are within the GBR, does that add an extra layer of support for?
I'm not sure that it does with this particular patient population. It does with a lot of our other insurable patients. But with this population, there's no coverage for them anywhere, so it doesn't.
And they can't obtain coverage.
I'm sorry?
And they can't obtain coverage.
Not for, we looked into it for HD. We've looked at everything creative that we could think of, from the potential of taking out an insurance policy on patients. We couldn't find a way to do that even. We found there is some, I don't know whether it's Medicaid or a Medicaid-like service coverage for HD for undocumented patients, but it is so low and so sporadic, and the red tape associated with it is so bad that no center will accept those patients without a contract from the hospital.
Thank you.
Yeah, so this is not an uncommon situation, and it's predictable. And for me, this is calling out for some type of a policy, because otherwise, what's happening is you're putting the burden of making this very difficult decisions individually, on a case. And so, what criteria are you going to use? And to me, these are discussions that are going to have to be made by society, and trying to get that input. Now, the fact that this is a difficult situation is nothing new. In fact, we confront it all the time, and the most common is I'm sure most of you are familiar with EMTALA, which requires emergency departments to treat and care for patients who are stabilized without assessing their ability to pay. So Congress passed that law, and that's been the law of the land for quite some time, but there's no funding with it. So it's what many people call an unfunded mandate. So it's kind of, here you do this is we're demanding that you do that, but on the other hand, hey, you got to figure out how to pay for it. So there's a lot of societal and medical and ethical pressures to provide particularly this type of care and other care, yet when it comes time to pay for it, most people go silent in terms of coming up to pay for it. So, previously the hospital has provided uncompensated care as part of its original mission, and then they distribute that uncompensated care and the cost of those who are paying for it through third-party payers. But you can imagine that if the cost of uncompensated care continues to rise, then that money is going to be increasingly distributed, or has to be distributed among those who pay. And so at some point you're going to reach a tipping point. And these particular cases are highlights of that. The other thing that to me has changed in the 20-some years that I've been here is that people talk about hospitals in their catchment area, especially in the area of population health. And I don't know if it's cynical of me, but I've decided that Hopkins catchment area is the world, literally. And it's not uncommon for patients who are in a foreign country, need advanced care that they cannot receive in their country, fly directly to the United States and specifically Baltimore and present to the Johns Hopkins Hospital for care. And we take care of them. And so that raises a lot of issues. And in the days when that type of care was not terribly expensive, it wasn't an issue. But now, when you're talking about hemodialysis, when you're talking about biologics for cancer therapy, people's medical bills, can routinely and easily run about $250,000. It raises a lot of these other issues, and you reach points where it becomes difficult, if not untenable. So I don't have the answer for these things, but I think at the very least it needs to be discussed, and I think there now needs to be policies put in place to address the new realities that we're facing.
Thank you. Louise, regarding thinking about oncology and the medications for oncology patients, how would you address something like this?
So I just want to do a little definitions and walk backwards a little bit. So while this case is for a party that we're referring to as undocumented and uninsurable, this conversation can be translated for folks who travel on visa and show up usually through our emergency department, through an admission, and then are diagnosed with something that requires additional therapies before they return to home. And oftentimes those patients will say, I in fact plan to stay here in the United States. In fact, I plan to stay in Baltimore. And so we have two sets of patients. We see them and talk about them pretty differently. And so for the patient who travels on an active visa status, those who have flown here by and large have come by plane with an active visa. And you can see some of those patients who extend the time of the visa, so they then become undocumented. So I just want to do a little definition and clarification. So for folks who travel with an active visa status and are diagnosed oftentimes in home country and then come here as a pocket reputation, we are often, you hear the words emergent admission for stabilization. And so that really is the definition that Dr. Locke is referring to even on the Intella when we get transfers in. We are to stabilize that patient and address their emergent status. Once we've stabilized the patient to discharge, the question mark then you all face, which is, what do we do now? Because the patient has additional kinds of needs, whether those are pharmaceutical needs or they are additional therapy needs, there are needs at large. For this case, this patient also has social needs. So he's got an unstable housing. So, and in essence, you've got a homeless party now. You've got no caregiver. So while there is a patient on dialysis, they actually need a caregiver, and so you've got an absence of that as well. So there's financial implications, not only for hospital, but for cost of living in the general community. So how is he going to eat, the utilities, and the like? And so those social determinants of health that we all talk about on the sort of pinwheel that's on Epic now, those are all question marks for this patient. And then translate into who's going to pay, and in some ways, this hospital feels an obligation to answer some of that, and we will. And as Melissa talked about a patient on dialysis, we're not even beginning to talk about the other kinds of costs. So not to make this just a really heavy and down conversation, but that's what's on your plate, right? That's really what you're trying to manage and come to solution. For folks who are, again, on visa status, the Cancer Center in particular gets a bad rap in that we are asking those patients to pay in advance of care. No different than our colleagues in the international office who actually travel through the international communication and make advanced plans to come. They too are required for deposit that may be embassy sponsored, or it may be their own personal finances deposited. But we are considering folks who bypass the international programming here and travel by air through BWI in the same kinds of ways. So just so you understand sort of the method of madness behind that. And we ask patients to put forth the deposit and then proceed with care. We are absolutely trying to repatriate them back to their home country and tell them up front, you have a particular malignancy with a limited life expectancy, you need to go back home. And we are more than happy to make accommodations back in home country by making contacts, phone calls, and the like. And believe it or not, in a lot of countries that you would think do not have access to care, there in fact is. And there is actually, Cindy would probably nod, there's actually some fairly good hospice and palliative resources in those countries, and we make connections for them. Everyone would like to stay in the United States, for sure, but there are realities. So for undocumented living here, who are uninsurable by definition of that, we have a TAP program, and our TAP is 10 zip codes surrounding the geographic footprint of Hopkins and Bayview. And there's some conversation and policy will be coming forward and clarification of policies to try to widen that for those patients, not visa holders, but those patients who are claiming a residence for a longer duration of 6 months to a year and have evidence of things that we can provide some support. We again would have that same conversation about repatriation. Can we get you back home because this is not sustainable? So I'll pause there and let the rest of my colleagues jump in.
Allison, do you have some thoughts?
I think what's a challenge in this particular case is what we've all discussed, is that this patient is not insurable because the patient is undocumented, they don't qualify, or they wouldn't qualify for programs like Medicare or Medicaid that, for instance, another individual may qualify for if they are documented and starting dialysis. I think looking at this on just the individual level, where we would normally tap into resources, there just are such limited resources. We have, TAP if they live within those zip codes. There are some other similar programs in different counties, but there's such few community resources that we can rely on to help fill in the gaps for this type of patient. And as a social worker, and particularly as a social worker on the unit, that's just really frustrating. This is a really hard case. Here we are working with a gentleman who is young and sick and needs a treatment, but we don't have the resources to help support that treatment. And it can be certainly an ethical challenge for the team, but I think also individually as providers and clinicians, this is an ethical challenge for us as well, of how do we provide the best care possible to one patient when they don't have the same resources or access to the patient next door. I think that's where I would really struggle just personally with this case. I think looking beyond just the case that's presented though, what some of our folks in the lease allude to this is perhaps individuals who do have access to Medicare but can't afford treatment or can't afford types of resources that would be best for them, such as an assisted living or other interventions. We run into similar problems. We have access to more resources in the community, but we still run into financial barriers to accessing the best health care, and that's a challenge. I think that's where the ethics committee can come in, to have consults and to sit down and talk with the teams about how do we think through all these different problems.
So, great thoughts, great ideas. How would we move forward? And if a patient such as this, or another patient such as this, cannot be considered for the TAP program, how do we as a Johns Hopkins Society, how do we as providers, as caregivers, partner with the ethics team? Is this an ethics question? So how do we work through something like this? Can we come up with policies and procedures at the very beginning when we see the patient in the emergency room and we know that they're going to be admitted? Is that something that the health system or the hospital should do? I don't know that this question has ever really been entertained or asked.
I would say that it's something that we're looking at on a daily basis because of the scope of this problem and I guess the degree of acceleration with it. And one of the first things that we've had to do, which to my shock we had really not done as an institution because we were so decentralized as we've historically been, these costs were all spread across departments. So nobody knew, up to about 18 months ago, nobody knew how much we were spending for uncompensated HD, for SNF, for ALF. It was all spread across departments, so it really took us about 6 to 8 months just to get our hands around that and to put it into a big spreadsheet so that we could look at what our current spend was and looking forward what we were obligated to with any patient. And in getting to that, we found, for example, that we had increased over the past 2 years our spend in assisted living facilities by something like 300%. So as a health system now, we are looking at the potential of contracting with a company that just does assisted living work to help us find better ALFs, to help us in negotiating rates, to do things that will spread our money further. It's not going to make the problem go away, but it'll maybe make us a little more facile with how we deal with it, and then to be able to engage them up front when we have a patient that we know is going to need that type of support. But that's one thing. The other thing is that we're working very closely with our governmental relations compatriots to be pushing in Annapolis and actually on Capitol Hill for changes or at least recognition of the scope of this problem so that they can help us with things that we now have data to say this is what we're paying. And we sit on a statewide group with the Maryland Hospital Association for post-acute care and trade war stories every time we get together. And what we're faced with, LifeBridge is faced with, MedStar is faced with, UMS is faced with, and the poor community hospitals that get these patients that might not be part of the health system have the same issues, and they truly have nothing in their toolkit. So I would say, to me, it's not so much an ethics committee consult kind of issue. At times it might be, I'm not saying it never is, but it's really more of an upfront recognition that this is going to be a problem. Where do we need to escalate it? Where are we going to have to get approvals if it does come down to a lifetime contract or a 3-month contract or housing for 6 months or something like that? And we're actually in the process of trying to put policies and procedures to the extent that we can together for that in our department. But like I said, there is some degree of concern about not being too specific, particularly with the lifetime type things, because frankly, if the word gets out that Hopkins is signing lifetime contracts for patients with no ability to pay for hemodialysis or housing support, or in some cases, our most expensive cases are patients that we're paying for lifetime support for dementia care and very high-end assisted livings, we'll be out of business very quickly, or we'll have these patients in our house forever because we won't be able to discharge them.
So I know there's a lot of clinicians in the room, a lot of social workers in the room. So I'd like to open it to the floor and get your thoughts, opinions, ideas of what we can do. Suzanne does have a microphone, and I am happy to give up my microphone.
I'd actually like to say that I think this is, while it is an ethical issue, an ethical issue, I think it's also a human rights issue. If we look at this from a standpoint of having the right to basic care and safety and well-being physically and mentally, and while people in this population with lower socioeconomics, the evidence is there, the evidence-based research to show that they often have mental health issues too. So now we're adding another layer to that at times, not for everyone. So I think it's even broader than just the ethical issue.
I agree. Do you have a solution? Hey, John, can you hold on a second? Go ahead.
I want to challenge some of the comments that have been made. First of all, in the words of Johns Hopkins, and I can't quote them directly, but the founding father of these institutions talked about providing lots of care to the poor of the community. That was the original motivation for the foundation. I think the problem here is really one of social and distributive justice. It's well known that not-for-profit organizations like ours get tremendous benefits from the public who we don't pay taxes, there are all kinds of other benefits, police, fire, all these other things. And there are lots of work by the IRS against institutions like ours saying we don't commensurately give back to the community what we get from the community. In yesterday's Journal of the American Medical Association, Jerry Anderson at the School of Public Health published a paper that talked about how elite institutions like ours give less proportionate charitable care than smaller and less wealthy institutions. So to me, the solution to the problem is not for this individual patient. It is to ask the question, what is an appropriate amount of charitable work that we must do to answer the mission that Johns Hopkins laid out? And I think we have to ask that at the board level. What is the appropriate budget for charitable care? Is it commensurate to what benefits we get from society? And stop saying we are doing everything we can, because I don't think we are. I think there's a lot of room to improve, and the question is, who should be making these decisions at the board level? I think there should be a lot more patient community participation in budget setting for this institution. The providers, nurses are looking to go on strike or unionize because they feel they're not be providing adequate resources. All of those have to be looked at in the context of how will we take care of these kinds of patients. And everybody knows administrative costs are the fastest rising element of healthcare, and CEOs of big institutions are paid millions of dollars, and the question needs to be asked, is that appropriate also?
That's a great point, thank you. So what happens when that budget runs empty?
When we get to that point, I think we can discuss it. Until then, I think we have room to go.
You think the margin's pretty big, huh?
I do.
Okay.
But I
That's a
feel
great
like,
point, thank you.
I feel like when Johns Hopkins said this, it was a very different picture than it is today. So I think we're looking at vast differences in supplying healthcare for all of the undeserved population. So, I mean, he couldn't possibly have imagined moving forward where we would be. It's a humongous financial difference in his statement then as to what it means for us now.
He challenged us to be
Well, if I
better.
could partially answer your question anyway. First of all, it's a very fair statement and something that we take to heart. And I would say that our social workers and our case managers on the floors, who are the folks that are making all of the arrangements for any patient that crosses our boundaries, are doing so without thought to how that patient got to their floor and what their social circumstances are beyond what they need to do in the post-acute world to meet those needs and to truly ensure a safe discharge, which is our moral obligation and our regulatory obligation for that matter. And so we do look to what must we do for this patient, and that is what leads to paying for hemodialysis, paying for housing, paying for SNFs, paying for home care, paying for sitters, paying for aides to go into homes, developing community health worker programs and peer recovery programs, and all of these things to support our patients. Is that enough given our total budget and the percentage of it that might be dedicated to charitable care? I can't answer that question. I'm really interested in seeing Jerry's paper to find out what he says. But I do agree that there is a board level commitment that is required to this and some direction, and that it is complicated in the very rate-regulated setting in Maryland as compared to elsewhere in the country where there is a lot more leeway. Not saying that as an excuse, it's just something that complicates what we do and how we do it. But you asked a very fair question.
So I'm going to just add on, because it's something that I mean, there's a couple of things that I agree with what you said, and some things that don't quite agree with, but it specifically raising this to the board level. And I'm not an ethics expert, but rather than focusing on these individual cases, I would wonder and bring this to the ethics committee, is it ethical not to have a policy to address these things? And to me, when I think about this, I don't know how many of you are as old as I am, probably not too many, but there was a show when I was a kid that was called Queen for a Day. And I don't know if any of you remember this. You couldn't YouTube it. It was actually on TV for quite some time. It was, in retrospect, a grotesque show. They would take 4 or 5 women who were impoverished, and they would each tell their sob story, and there would be a prize that would be awarded to one of them at the end. And whichever one gave the most compelling story would get the refrigerator or the vacation. And then when they would award the prize, and they would put a crown on the woman and put a cape on her and some roses, the camera would continue to focus on all 5 women so that you could see the 4 who didn't win sort of break down and cry. And so when you're offering hemodialysis, I think there needs to be some kind of an institutional decision about whether you're going to offer or not, and not require individual compelling circumstances for each one, because otherwise you're going to end up in this situation as to who's deserving and who's not on an individual basis, and which can give you the most compelling story. And to me, that just seems a little bit too much like Queen for a Day, and not a good and rational way to allocate scarce healthcare resources. So I think that this does need to go to the board. I mean, there are regulatory requirements that require Hopkins. So there's 2 issues I want to bring up. One, there are regulatory requirements that require Hopkins and other hospitals in Maryland to spend a certain amount of money in uncompensated care. And then the other thing I would say is you bring up the point of Hopkins and the mission of the hospital, which was to care for the community of Baltimore, regardless of their ability to pay. And for the most part, I think that in all the meetings that I've been in and familiarity with administrators, they take that very seriously. The question is, what defines the community? As you pointed out, in 1900, somebody who lived in Baltimore is somebody who's flying from Africa to seek very expensive care that's not available in their country specifically for receiving that care. Are they part of the community as defined by Hopkins? I don't have the answer to that question, but those are clearly issues that we're facing now in the era of, where the world is really small and anybody in the world can arrive at the Hopkins ED within 12 hours. Regardless of where they are in the world, and the care that they can receive, 50 years ago would be, maybe $5,000 or $10,000 worth of care. People can now receive, easily $500,000 worth of care. So those questions, I don't have any of the answers, but I think those are the questions that need to be asked, and I think it points out to why I think it's incumbent upon somebody at some level, whether the state or the board, to come up with a policy so that people aren't, and individual social workers and case managers or COOs having to make an individual decision on a particular case. So that's my comments, and I welcome anybody else. And again, I'm not an expert in ethics, but that's just sort of how I think, because we struggle with these things, I think, much too much. And it doesn't, it really, as a physician, this comes up every day wherever I turn. It's not just these dramatic cases, but what do you do, for a nurse who's working and then gets hospitalized and has a $5,000 copay? Is it ethical to make her pay the copay when she's struggling, or he or she is struggling to have other things, and should the hospital step in? We get those all the time. Or, somebody has Medicaid and they're in the donut hole, and they don't have $3,000, or they don't want to pay $3,000, where do you draw these lines? So these are, I've sort of advocated for some type of what we call a FAFSA. Those of you, if anybody has sent kids to college, it's this very complicated formula, but it's been developed because you're trying to distinguish about what the universities and colleges expect someone to pay based on your financial resources. We don't really have that for medical care. And we're probably at the point where we probably need something like that, rather than taking that decision and requiring an individual social worker or case manager or administrator to make that decision.
Thank you. There's a number of folks in the back.
I think there are different factors and different layers, attributes to this reality. In my experience, more than the illegal immigrants, the documented immigrants are the biggest expense for this country and for the healthcare systems. The reason is these people know the system very well. They invite their families and kin. For example, if I invite my mom, she comes and after 3 months, she becomes undocumented given her health conditions. And then I have no liability, even though consciously I disclosed at the embassy and gave the financial assurances, and then the healthcare systems of the country doesn't have mechanisms to emphasize and make the sponsor to be accountable. That is one part. And the other part is that, for example, if I'm inviting somebody, I do know that that person has healthcare issues. It's obvious that I buy travel insurance for 100,000 or 200,000, which is similar like your supplemental insurance. Healthcare systems has no mechanisms to lay their hands on that money. If the patient dies, they have the choice to get that money, or they work through the lawyer to distribute as they like. If at all you are thinking about a policy, you have to look into the ways to tie up with the travel insurers who are selling these policies, and what are the ways that we can tap into those resources, and also to go hard, what are the ways to make the sponsor accountable in these documented immigrant situations.
Thank you, John, I appreciate that. Other thoughts, ideas, comments from the team? It's quiet.
So I'll complicate the conversation. Dr. Luck alluded to this thought of US-based with health insurance and the out-of-pocket costs associated with healthcare. So the literature's pretty rampant right now with the financial toxicity conversation. HICA kinds of illness associated with that. And oncology gets a lot of publications these days because of the cost of our care, mostly pharmaceutical driven. And so the conversation generally goes that there's an accusatory tone to most of the documents in relation with hospital costs, physician costs, and pharmaceutical costs, right? And what happens for people with out-of-pocket balances? And so the press is also pretty aggressive when it's been doing its latest exposés about how hospitals utilize outside agencies to attempt to collect on those out-of-pocket bad debts, right? So how, from an ethical perspective, and for a little bit of our conversation, how do we balance out those sets of behaviors for which not only Hopkins, but the entire healthcare industry across the United States applies those same principles? How do you balance that against what we're having this conversation in the case example for an undocumented individual, uninsured, or for a visa holder traveling? Love your thoughts about the incongruency of those two and how do we make some sense of that?
Such a tough topic that no one has thoughts.
And we have to call on people.
Oh, okay. You take that side of the room, I'll take this side. Okay.
Brave
We
hand.
have a taker in the back.
So I don't know anything about the details of how undocumented or documented immigrants receive care at Hopkins, but an important distinction to make would seem to be how to distinguish between people who we know have means but are coming here to take advantage of the system versus people who are truly indigent, whether or not they're a citizen, a resident, or undocumented. And what I didn't hear today in the conversation is anything related to advocating for people who are undocumented to help them get on a path to citizenship. So for folks who are coming here who are not documented and are not uninsurable, it's not a law of nature. Is there something that Hopkins can do to help them to get on a path to citizenship so that it doesn't become simply an issue of quote-unquote scarce healthcare resources or being on the hospital's dime, but rather on society's dime?
There's a comment right here.
Hi there. So I'm not going to answer this question. Maybe I can later. This is Kathleen. But to your comment, in my clinic, we have established two volunteers legal volunteers from the Baltimore Law School, American Legal Partnership. And there's been, what our experience has been the following. For many undocumented immigrants, there's no real pathway given the current immigration policies to citizenship. However, even for those immigrants, getting legitimate advice about whether it's worth them hiring a lawyer or not is actually quite useful, and it gives them at least some peace of mind. But I was actually surprised. There were several of patients in my clinic that were undocumented and I thought had no legal pathway who were in fact assessed, and there was a legal pathway to citizenship. So even if that's 2%, that's still 2%, and I do think that those partnerships are of high value. In my case, it was a volunteer lawyer faculty who helped me, but I think there can be ways of expanding that model and doing it in a more systematic way.
So Kathleen Page, Dr. Page is just joined TAP's leadership, and Adriana Moore is with her, and so we are indebted to both of you for your leadership in TAP.
I think there was a comment in the back. Somebody had their hand up.
Responding to the gentleman from Nate's question, and I'm not 100% certain about this, so anyone can jump in, but I think with regards to path to citizenship and getting that coverage, that medical coverage, I believe there's certain circumstances that automatically disqualify people, such as felonies. Can anyone here speak to that? Perhaps you?
Yeah, so I don't, that's one thought, but I think it's, for the most part, for this conversation, this path to citizenship might be a little bit of a red herring, because generally people have to get a green card, and to qualify for Medicaid, you actually have to be a green card holder for 5 years. So for most of these circumstances, it's not really applicable. And then the other thing is, in terms of healthcare resources, I mean, the vast majority of these people, it's just going to give them the opportunity to be eligible for Medicaid, which is still subsidized. I mean, it's government health insurance, so it's just by a different name. I mean, it's just a bit of cost shifting rather than uncompensated care. It's Medicaid, so it's still, you're not magically reducing the cost of care. I mean, you're just changing how you're going to pay for it. And again, this is a very challenging situation, and again, it's one that we've never been in. And then there's 7 billion people in the world, and does Baltimore, and Hopkins and the United States in general have the resources to provide health care for anybody in the world who is seeking it? I mean, it brings up all of these very complicated issues, and they're issues that, again, that I don't think we've ever faced before in the history of the planet, because one, there's 7 billion people, never had that before. 2, air travel has made access to anywhere so easy, and now the cost of care for whether it be hemodialysis or cancer or any number of things is so far expensive. I mean, we're struggling how to pay for all these things, even for people who are citizens of the United States. So, and then the other thing is that, and I'm not an expert on this, but undocumented migration has changed dramatically in the United States, whereas typically, and again, I'm not an expert, but the the stereotypical was a young man from Mexico or Central America who would come and work for a few years and then return to his or her country, and obviously their healthcare costs were very low and limited. And now you're having people who are coming here moving permanently, and who are now not returning and who are aging, and just like the rest of us, your healthcare costs go up as you get older. I mean, when I was in my 20s, I probably went to a doctor once in 10 years. I mean, and but now I'm older, I mean, and that just happens, that's just life. So these are all issues that I don't think we've faced ever before, and I don't, obviously the entire country is struggling with all of these issues. I mean, it's really a hot button topic, and I think that they become most acute in cases like this, and really Congress and the country in general has been reluctant to deal with these issues head on, yet the reality is these cases are happening, and then we're requiring our hospitals to deal with them on a daily basis and really putting them in a difficult situation. There really isn't a clear answer, and we aren't getting their support from society in general on how to handle these issues. I'm going to let Dr. Page speak, because she's an expert in this stuff.
An expert. I do agree with you that, 15 years ago, most of the immigrant population in Baltimore was very young and very healthy because, many people were walking through many, many miles to get here. Most people are staying here, and they are aging, and those costs of care may increase. I guess a couple of comments, and I don't think I have solutions, but at least some thoughts. One is that TAP has traditionally been a way that undocumented immigrants can have received access to care at Hopkins. We have a lot of experience doing this, and to that question of, do we provide care to people who are coming from Asia or on travel visas or whatever, we have a pretty clear policy. TAP is really designed to help primarily to help the local community, and so we do not accept patients who have travel visas. We have been now in lots of discussion with what's called revenue cycle, because as you may all know, the financial assistance policy at Hopkins has changed. In some ways, I think a good way, but I think there's a lot of conversations around it. There used to be a restriction to qualify for financial assistance at Hopkins that really was, you had to be a U.S. citizen, I think a permanent resident maybe, but you could not be a foreign born undocumented individual and receive financial assistance. That clause has been removed, and I think that's a welcome move. However, these types of questions have come up. What does that mean? Are we taking care of people, health tourism and all that? And then lastly, the two other comments I would say is that I totally agree that to be fair and equitable, it is important to have procedures, because otherwise it does end up being one, if the person emails the right person who was in a good mood that day, you may get hemodialysis, and if the other person emails the person who was in a bad mood, you don't. And I'm exaggerating, but I don't think that's the way to provide equitable care. And to the comment that I think is so important about distributed justice, I think a question that I have grappled with as I assume this role in TAP is that there are ethical precedents on how to distribute scarce resources. A good example that comes to mind is organ transplantation, for example, and there are committees and well-established methodologies to try to do this the best we can. What I don't have and I think Melissa alluded to this, what I don't know is when we're distributing, we're talking about charity care as a scarce resource. What I don't know is how scarce is that? How big is that pot? How do we make decisions about this distributed justice if nobody in the room, or maybe someone who does, knows what that means? And I think that's a big struggle, because it's, on the one hand, it sounds like there's none, but we know there's some. The question is how much.
And how is it allocated?
Right, I mean, that's where I think structures and policies and committees can help, and ethicists can help us decide how to do this in an equitable way.
Thank you.
I
I would love more comments. And John, again, in the back. I want to be cognizant of folks' time. That clock is 10 minutes fast, so it's almost 1 o'clock.
10 minutes left.
I would like
Oh,
to-
yeah, go
I
ahead.
would like
Good at math, really good at math.
I would like to join with her. And apart from the costs alone, what are the ways that we show that we care for this patient population? This is not the Hopkins problem alone. This is the social justice issue. There are organizations like nonprofits and NGOs and for example, Lutheran World Refugees is right in the harbor. So what are the ways to partner with these external agencies and make the appropriate referral when you have these patients? And is that would be something that we show compassion towards these people?
Right, and that absolutely shows compassion, John, and I love the idea, but to do that takes more resources, right? Internal resources.
I actually work with this population, and I think that the immigrants being undocumented or not, that are already part of the local community and are here to stay, a lot of the times they're put in work positions where they're more likely to have work-related injuries, or they're exposed to chemical substances, or in a way are saving the citizens from being exposed to those environments. So they already are part of the community, and in terms of, they are contributing to the community and are part of the community, and they're here long term. But in terms of people who are coming for very concrete reasons to escape a lot of dangerous, unstable situations. And I think the way to prevent that is to provide them stability, and the way to keep them from in their own countries, and maybe one of the ways to keep them from coming here just for healthcare is to take the healthcare to their countries, like Hopkins does when they send out the doctors. So just like if somebody has stability, nobody wants to leave their country and their family and make that trip up if they have stability in their own country. So therefore, if they had access in their own country, by maybe sending out doctors or teams, they would be less likely to travel here.
Yeah, great idea, and that does happen with a lot of our physicians and colleagues and providers that travel to other countries for programs. I'm going to ask Mark or Cinda if you have any additional comments.
Just ask one additional question. So if we did institute a policy and came up with an algorithm or scheme for deciding who gets a resource and who does not, my question from a palliative care perspective would be, for those patients that we say, no, you don't get access to this resource, what is our responsibility to them?
And I would ask for those that we say no to a solid organ, for those that we say no to a bone marrow transplant, for those others that we say no to, what is our responsibility to them as well? I don't have an answer for you, but I think these are all great. Answer.
I have some thoughts, but not.
Not for you.
I've said enough.
When's
session.
Cinda, when's the next one? In March?
Third week.
Third week of March is our next Ethics for Lunch. Thank you all for coming. It was wonderful to have you.